Good morning. Today our topic is Endo Perio lesions. There is a strong relationship between the periodontal and endodontic disease. It was first described by the author Goldberg and Simring in 1964. So the periodontal and endodontic disease has strong relationship. It was first described by the Goldberg and Simring in 1964. And there is a pathway of communication. This periodontal and endodontic disease, there is a pathway. So the periodontal diseases affecting the endodontal also, or endodontic affecting the periodontally by the pathway of communication. The anatomical pathway and non-physiological pathway. And the anatomical pathway, apical foramen, the accessory canal, and the tubular pathways. By the anatomical pathways, the apical foramen. The apical foramen, that is the most direct route of communication between the periodontium and pulp. So the apical foramen is the most direct route of communication between the periodontium and the pulp. And the accessory canals and tubular pathways. Non-physiological pathways such as incidence of a root fracture, when the lateral condensation, the vertical root fracture and non-physiological pathways. And the classification of endoperial lesion, there are 2 or 3 classifications given by one classification given by Wien and the other classification given by Simon and Frank in 1972, and the Grossman classification. So we are following the Simon, Glick and Frank in 1972 the classification, that is primary endodontic lesion, primary periodontal lesion, primary endodontic lesion with secondary periodontal involvement, and primary periodontal lesion with secondary endodontic involvement, and true complaint lesion. So the Simon, Glick and Frank classified into 5 categories: primary endodontic lesion, primary periodontal lesion, primary endodontic lesion with secondary periodontal involvement, and primary periodontal lesion with secondary endodontic involvement, and true complaint lesion. So that classification follows. And the diagnostic criteria. So how will you diagnose is an endoperio lesion? By the vitality test, radiographic evaluation, pain and abscess formation, mobility, percussion and palpation. And on the vitality test, the non-vital tooth that may indicate the primary pulpal involvement, and a vital tooth that indicates the primary periodontal involvement. And the radiographic evaluation, and the apical radiolucency or loss of bone at the alveolar crest. The apical radiolucency indicates the primary pulpal disease, and the bone loss confined to the coronal one-third of the tooth that is associated with primary periodontal diseases. So the vitality test, the radiographic evaluation, the mobility, pain and abscess formation, and percussion and palpation are the diagnostic test. On the vitality test, the non-vital tooth may indicate the primary pulpal involvement, and the vital tooth indicates the primary periodontal involvement and non-vital tooth indicate the primary pulpal involvement. And the radiographic evaluation, the apical radiolucency indicates the pulpal disease, and the bone losses, the coronal 1/3 of the tooth, that indicates the primary periodontal disease. And pain, how it is the pain? Pulpal pain is usually sharp, and the pulpal pain, how it is? It is sharp, and the periodontal abscess and the pain is dull pain, and the mobility and generalized percussion and palpation. And the treatment option, and what is the treatment options? Root canal treatment for the primary endodontic lesion. A root canal treatment. Primary periodontal lesion, the periodontal treatments. And the primary endodontic secondary periodontal lesion, root canal treatment first followed by the periodontal treatment after 2 to 3 months. So the primary endodontic with secondary periodontal lesion, the root canal therapy first, then after 2 to 3 months the periodontal treatment. Primary periodontal and secondary endodontic lesion, the treatment indicates the endodontic and periodontal treatment with the GTR. And true combined lesion, endodontic therapy, then the periodontal treatment procedures including surgical procedures like amputation, hemisection or bicuspidization. So we are literally going to the pathway of communication between the pulp and periodontium. Extension of infection and inflammation from pulp to periodontium or periodontium to the pulp can occur through any of these pathways of communication. This developmental, pathological and iatrogenic. The developmental, it is anatomical factors we already spoke, and the iatrogenic factors is vertical root fracture and root. So the developmental origin, apical foramen, accessory canal and lateral canals, absence of cementum, permeability of cementum, developmental groove, enamel pearls and projection. Pathological origin, destruction of the sharpish fibers, that is empty spaces on the root, idiopathic resorption, less cementum due to external irritants. And the iatrogenic factors, pathways, it is iatrogenic pathway, that is root planing, exposure of the retinal tubules, and endodontic treatment while the accidental lateral perforation, root fracture and root. And the classification based on etiology by the Simon and Glick and Frank in 1972, primary endodontic lesion with secondary periodontal involvement, primary periodontal lesion, primarily periodontal lesion with secondary endodontic involvement, true campaign lesion. So the 5 type based on etiology by Bean in 1982. Type 1, primary endodontic lesion mimicking the periodontal disease. Type 2, endodontic lesion in a periodontally involved tooth. Type 3, primary periodontal lesion requiring endodontic treatment for healing. And type 4, primary periodontal lesion secondarily involving the pulp. By Grossman, type 1, requiring endodontic treatment only. Type 3, type 2, requiring periodontal treatment only. Type 3, requiring combined endo-perio treatment. And the effect of pulpal disease on the periodontium. Bacterial and toxic irritants in pulp, increased intrapulpal pressure, and the retrograde periodontitis, that is unresolved endodontic lesion. Inflammation begins apically and extends coronally, and the furcal bone thinner than periapical bone, and the first indication, that is thickening of PDL at the apical end. So the effect of pulpal disease on the periodontium. How the pulpal disease on the periodontium affected by bacterial and toxic irritant in the pulp, increased interpulpal pressure, and retrograde periodontitis. Effect of periodontitis on dental pulp. The bacterial and inflammatory products present at the time of periodontitis, they passes through the accessory canal, apical foramen, and dentinal tubules. They affect the pulp. And the difference between the pulpal abscess and periodontal abscess. And the pulpal abscess, it is associated with deep restorations, and the periodontal abscess is associated with the periodontal pocket. And on pulpal test, it is non-vital in pulpal abscess, pulpal disease, and the periodontal abscess, it is vital. And the swelling in pulpal abscess, it is localized, and fistula dislocated away. And in the periodontal abscess, it is generalized and localized. And how should it be the pain? Severe, and it is throbbing type of pain in pulpal abscess. It is dull and constant in the periodontal abscess. And coming to the detail in primary endodontic lesion, who classified that? Simon Glick and Frank classified. How many types? 5 types we have classified. In the primary endodontic lesion, causes deep carious lesion, dark restoration approximating pulp, history of pulpotomy, pulp capping, and the poor root canal treatment. And the symptoms: mobility, localized bone loss, and tenderness to percussion, and the sinus tract, and swelling. And the primary endodontic lesion causes by the any deep caries it is present, or any large restoration that is approximating the pulp, and the poor root canal treatment when not obturating the full length of the root, partial obturation and root. And the symptoms like mobility, localized bone loss, tenderness to percussion, sinus tract, and swelling. A patient come with pain will be differentiated with the periodontal and pulpal by tendering, the horizontal tenderness and vertical tenderness. The diagnosis: radiograph, pulpal vitality test, tracing of sinus tract, periodontal probing, and the treatment is conventional endodontic therapy. Conventional endodontic therapy.